This episode is brought to you by Bound Hat Company. Discover Bound Hat Company, where high-quality hats meet a greater purpose. Each hat is designed not only for style, but also to give back, with proceeds supporting charities like the PTSD Foundation of America. Whether for the outdoors or everyday wear, Bound Hat Company has the perfect hat for any occasion. Shop now at www.boundhatco.com and join the movement to support veterans and meaningful causes. Bound Hat Co. Style that makes a difference.
The following podcast discusses sensitive topics. Listener discretion is advised. If you or someone you know is struggling, call or text 988 to reach the Suicide and Crisis Lifeline for 24/7 confidential support.
Welcome to Survival in the Trenches, Life Beyond Loss, a podcast where we share the powerful stories of those who have faced extraordinary loss and found the strength to push forward and triumph. These are real journeys of resilience, courage, and hope. Join us as we uncover what it means to rise above, even in the darkest of times. Hello, everyone, and welcome to Survival in the Trenches. My name is Kelly Chandler. Today, we are honored to sit down with Dr. Leo Cabassa from Washington University in St. Louis's Healthy Mind Lab. Thank you so much for being here today.
Oh, thank you for hiring me. Very excited.
Absolutely.
Okay.
So we are here to talk about psychedelics.
Yeah.
And with that research, you have come together with two other women, Dr. Ginger Nickel and Dr. Rebecca Lester, to form CHIRP. Mm-hmm. Can you tell us a little bit about what CHIRP is?
Yeah. So the CHIRP, the Center for Holistic Interdisciplinary Research on Psychedelics, we love acronyms.
Yeah.
So CHIRP actually is the initial idea of setting up a center, an interdisciplinary center, so bringing faculty and investigators from different areas of Washington University, from different schools, different disciplines, to address sort of basic questions in the area of psychedelic medicines. And it's an interesting investment that Washington University is doing through their new strategic plan of building the interdisciplinary work in the university. At university, people work in their own fields: psychiatry, social work, anthropology, law, business, and everyone's in their own world. But the challenges that we're facing with psychedelic care, for example, require multiple disciplines and different perspectives. So CHIRP, the idea of CHIRP is to bring together all these different experts to address the fundamental questions that we're trying to address with our center, which is like, how do psychedelics work from the brain all the way to society? Who will psychedelics help? Who will benefit most from psychedelics? Who could be harmed from psychedelics? How do we, as these medicines and treatments hopefully become approved and are more used in the community, how do we integrate them into an existing mental health care system? So those type of questions is what we're interested in addressing. And CHIRP provides us initial investment to begin to address those questions within a university. And WashU is actually very innovative in this sense of making this initial investment on us and building this infrastructure.
That's phenomenal, and congratulations,
Yeah.
because that's a testament to the work that's being done when you have that type of backing.
Yeah.
And I love that you brought up the silos that a typical university or field of research, you're very deep, but you're going broad, horizontal, if you will, and you're making sure you're addressing different areas of study. That's a fascinating approach, and one that's really more applicable to everyday life and how you're going to use the medicine.
Yeah.
So prior to getting into the details of what's going on through CHIRP and the Healthy Mind Lab, I'd love to step back in time and talk about you as an individual and your background and how you got to this point.
Oh yeah. So no, I think that's a question. I've been reflecting on that as well. So I'm originally from Puerto Rico. I'm a Puerto Rican social worker. I went to school here at Washington University, did everything: my BA, my MSW, my PhD. And the area of work that I've always focused on is how to address the health inequities among minoritized populations, so Latino populations in the United States and Latin America, Black populations in the United States and Latin America, and really thinking about how do we get services that these populations need? How do we address the barriers that people face when they're trying to seek mental health care? Once they get there and receive care, that care is of high quality, addresses their needs, and is culturally appropriate. Over the years, I've specialized in improving the physical health of people with serious mental illness. So these are individuals that have schizophrenia, bipolar disorder, major depression, and that population tends to die much younger than the rest of the population. They tend to die almost 25 years younger. And many of those factors are related to their physical health. So diabetes, cardiovascular disease, obesity, all of those things are more prevalent in these populations, and there are services that we can provide to help address that early mortality. So most of my work has focused in that area. How do we bring interventions to those populations and make sure those interventions are culturally appropriate for their needs. So that's where I've been doing for the past almost 10 years now. And we have different interventions that we have adapted and implemented. The other part of my work is I'm a researcher that's interested in making sure the evidence that we have actually gets to the communities that most need it. That's the area of work that we call, in my work, we call that implementation science. How do we bring the evidence that we have to communities that need it and make sure that that evidence actually helps the communities? So my work has focused on understanding what the needs are in the community and then bringing those interventions to the community. So I'll give you an example. We finished about 3 years ago a study where we went to supportive housing agencies. These are places where people who are chronically homeless go and live, and are provided an apartment, a place to live, and they have many different physical and mental health issues, and we brought interventions to them. And we brought an intervention that was delivered by people that have lived experiences with serious mental illness, peer-based interventions. And the reason we did that is because those individuals have walked the walk. They have lived experiences with dealing with schizophrenia, with coping with physical health issues. So they're great individuals to deliver this care. So we develop this intervention and deliver it in supportive housing and work with peer specialists in these organizations to test whether these interventions work and how do they work. And we did this in New York and in Philadelphia at that time. So it's that type of work. I'm also very interested in not only does these interventions work, but how do they work? What is the experience of the clients that are receiving these interventions? And that's part of sort of the other part of our work, really understanding their point of view. Is these interventions actually working for them? And how can we use that knowledge to improve the care? So that's sort of the work that I've done as a social worker. We're trained, our work is really applied social science. So how do we take evidence and make sure that it's improving some aspect of our world? And the well-being of people with mental illness has been sort of the area of work that I've been focusing on.
Yeah. Sure, and it's fascinating. Yeah. And it sounds like in a very broad perspective that you're advocating for the underdog is the way I think of it. In a very basic term, you're advocating for people that don't have the level of access that maybe the overall population does. Yeah. And is that based on personal experience that you saw, you witnessed?
So I think there's two things for that. One is being a Puerto Rican and I grew up in Puerto Rico, so we are American citizens, but we're treated as second-class citizens, and we don't get the same type of medical services, for example, in the island that you will get if you were in the mainland. Even though we pay Medicaid, we pay Medicare, we don't receive all those services. So growing up in an island that is a territory of the United States, you see the impact. Having moved to the United States, also seeing the deep inequities that happen. If you're Latino or you're Black, you're more likely and at higher risk of suffering from diabetes, from depression, from other physical and mental health issues. And then the lack of access to high quality care also becomes an issue. So really thinking, from my own personal experience, seeing the challenges that the healthcare system has really motivated my work. The other component is that, I've been reflecting on this. When I was going through my doctoral program, the federal government in the United States had done major reports on health inequities. This is in the 1990s, early 2000s. And it was crystal clear that we have these major inequities between Blacks and whites and Latinos and whites. And a lot of it has to do with access and quality of care. So I came off through my career understanding that there's these inequities, and the next step is what do we do about them? So that's where sort of my science has come into play. How do we use the tools of science to help address those inequities in care? Personally, I had family members who have suffered from mental illness, have suffered from chronic diseases, and seen the challenges that it is, even when we have the resources and the connections and the know-how and the expertise on how to get someone to care is still very challenging, particularly in our mental health care system in this country. So all of that has shaped what I do, what I bring to the table, and inform the science that we do as an important component of all of this. Yeah.
Which makes a lot of sense, because I feel like people that have that tremendous passion, it came from a deeper place.
Yeah.
And I sense that from you.
Yeah.
And that makes you the best type of advocate, because...
To certain extent, and I wouldn't call myself an advocate. I'm a scientist. I see myself, and I worked in different positions, but I work more in the sort of bringing science to bear on these issues.
Sure.
I have worked with policymakers. Previously, I was in New York State. Worked with the Office of Mental Health in New York State, and it was a great experience. I got to see how evidence can be used to improve care at the state level and work with state policymakers, but realize that that's not my strength. That's not what I'm not, how do I say this? I can bring the evidence, I can do, but I don't do the policymaking component of it. And I think there's people who can do that much better than I can. So I see myself as bringing that evidence for advocates to then use it and do that type of work.
And that makes complete sense. And let's talk about that science.
Yes. Yeah.
If you could tell me and the audience what your findings have taught you and what you've been able to share to influence change.
In this area of work, or like in where?
I would say we can start just maybe broadly, and then we can dive into more of the psychedelic research.
Oh, okay, yeah. So I'll give you two examples of how we brought sort of our science to benefit. So one of my earlier studies was around depression in Latino community. And I was very interested in understanding how do Latinos, Latino immigrants, make decisions if they're feeling depressed, if they're suffering from depression, how do they go seek help? And how do they connect to the health and mental health care system? And through those studies, by interviewing many people, understanding the path, we realized that there was a lack of information about what depression is in the Latino community and how to advocate for the care that people need. So we used that information, and actually we developed a fotonovela, which is basically a little booklet that tells the story of a person going through depression, but it's sort of like a comic book setting, and it's embedded in a soap opera narrative. So the idea is that I am entertaining you, and at the same time, I am placing information and educating you about depression, about how to seek care. And we use science with art to develop this tool. And it became an educational tool for the Latino community. And at that time, most of the information that was out there in Spanish, for example, was very boring. I remember doing therapy with clients and having the brochures from the National Institute of Mental Health and other organizations and giving it to them, and then the session is over and the person is leaving the brochure in this chair or not taking it home. Like, hey, why are you taking this? This is important information. They're like, oh, this is boring and it doesn't relate to me. So we developed this new approach of bringing art, a story-based approach of providing education. And we found that helped reduce stigma, increased knowledge of depression, and it also was a tool that people wanted to share with other individuals. So it was this idea of entertainment education. And that was a way that we brought our science and developed an intervention of this nature. It doesn't solve all the problems. The way that we think about it is a door opener, it's a conversational opener. You want to learn about depression, here's what you can begin to think about. And the characters in the story are actual real people, real Latinos. So people are reading this, they're seeing this, they see themselves in it, they can recognize either themselves or someone else. It brings a level of credibility, and it's also a funny story. Someone's cheating on someone, it's a soap opera, so someone's cheating on someone, someone's doing something over here, the family, there's crisis. So you're being entertained as you're also being educated about depression and increase their literacy levels of this. And we've seen sort of a good impact. So that's one way we use our science to inform interventions in another way. The other example is actually this connection between, for people with serious mental illness, they lack a lot of coordination of care. We have a broken mental health care system. People receive mental health care in one clinic and they have to go to another place to receive primary care. And some places are integrated, but the coordination of all that care becomes very complicated. And if you have schizophrenia, you don't speak the language, you don't know much of the medical system because you're an immigrant, this becomes a really daunting task to navigate. So we develop an intervention where we help someone navigate, a healthcare manager intervention to help navigate the health and the mental health system for those individuals. We show that it improves people's preventive primary care, it improves people's quality of life, people became more engaged in their health care, and people felt they had an advocate that can help them navigate our complicated healthcare system. So that was another understanding a need and then bringing an intervention to address that need. Is what we did. And we did that whole intervention by bringing doctors, social workers, but also patients to help us inform the intervention so that it becomes a program that people want to accept and want to actually engage with it. And we're now doing, that intervention is now being adapted for Puerto Rico. So we're working with different teams around that. So those are two examples of how we brought our science to inform some type of intervention and action from it. Yeah.
Very impressive work, and I'm sure it's very self-rewarding. So
it's been good. The reward actually comes from seeing the impact that it's having. And here's where science comes in. We make changes to intervention based on the data that we get. So there's things that are not working. Okay, why is it that not working? Let's figure out
sure.
why. So it's really testing something and really learning from that experience.
Absolutely. Yeah. You can shift and pivot based on the information you're garnering. And
that's right.
I love what you spoke, or how you spoke about the method of delivery. Sometimes it's about the method of delivery and making that real and relative to people versus having a manual that might have all the right information.
That's right.
If the method of delivery is ineffective, it's not going to work.
That's right.
There's going to be no connection.
That's right.
So you've been able to formulate that for that particular population, which is interesting. And I can see why it's so important to have someone within this organization of CHIRP to represent and inform the group about people that truly need this modality of treatment, because you're going to, and I spoke to Rebecca about this earlier, you're going to have that population of people with true mental illness that need a modality that is different, that is something that can be more effective. Yeah. And then you're going to have that population of people who can just pay for it because they want a different experience.
That's right. Yeah.
So you have to balance as a team, how do you move forward and commercialize those two different kind of entities, if you will?
That's right. Yeah.
So talk to us about your role in ensuring that those needy populations are at the forefront of the research.
Yeah, so there's a couple of things. One, this is a new area of work for me. So I began this work about a year ago. So this is the other thing, that CHIRP was basically developed over the past year, in a sense. So about a year ago, last summer of 2023, I got an opportunity to go see a training on psychedelic-assisted therapy. A great colleague of ours, Heidi Allen at Columbia University, had developed this grant where she's continued to do this work of training social workers and nurses. The people who are actually delivering most of the mental health care in this country are not psychiatrists, are not doctors, are social workers and nurses. That's the largest workforce out there delivering care. So Heidi and her team was really interested in, okay, how do we prepare this workforce for this potential new treatment that's going to enter the market? What do we need to do? So she did this wonderful training program where we went to observe the training that at that time MAPS was doing, which was the MDMA assisted therapy, and got an opportunity to see how they're training their facilitators and what this treatment was all about. I had read multiple books, read Michael Pollan's book when it came out. I've kept up with psychedelic work throughout my career, but had never seen it and actually see how they train their facilitators. That was a fascinating experience, and got to see the power and the promise of this particular type of care, particularly for they're treating PTSD, like treatment-resistant post-traumatic stress disorder, which any other treatment that I have seen is very difficult to treat. It takes forever, and most people don't get better. So this was a really eye-opening, but with the experience that I brought was like, oh, this is great, but the moment this enters the market, if people are not thinking about, well, who's gonna use this treatment? Who's gonna deliver it? What about the people who are most at need? This could all fall apart, or this is gonna be a treatment just for very high income individuals that have the resources. What about the public mental health system? So that's where I got very interested, because I saw, wow, there's a bunch of questions here that need to be addressed as we're thinking through. And that's where sort of my work in health equity and implementation science really kicked in. It's like, oh my God, there's many opportunities here that we need to pay attention to. And so that's how I got interested in this, and beginning to think about the studies that we could develop, that we have to bring that perspective from the very beginning. It's like thinking about implementing these interventions with the end in mind. Who is the workforce? How will this be delivered to a low-income Latino or in Black populations in a mental health care system that's broken already and that has many mistrust issues in this population? So those are the types of questions we want to address. It also, these treatments are not new. That's the other component. These medicines are not new. So it's also that history that comes in, and many of these medicines were used throughout the Americas. So also that history becomes really important here, and that knowledge that Indigenous communities have, how can we bring that to bear for this care? I see this as not only the medicine, but it's really the medicine and the therapy. That's where I see the power between this, that we're not gonna solve this problem just with a pill.
Correct.
There has to be this psychosocial, psychotherapy component. And this is a paradigm that, if it's done well, combines those in a very intricate manner that helps heal the individual of these different issues that our current treatments don't heal as much. So that's where I'm trying to understand that, and what that therapy will look like will be really important for this.
It's so interesting, because we touched on this in a separate interview. You do have the, say it's a pill, mm-hmm. and then you have the person that's involved in helping the individual through, and that is it's personal, and it has the ability to unlock the power of the combined treatment. How do you modularize that? How do you bring that to a commercialized status? How do you productionalize that? So I noted, with you, Ginger, and Rebecca, there aren't business people involved yet. How are we going to bring this to market and make it something that's sellable? And is that done by design? You want to focus first on the research, the treatment, how it can affect people, and then how do we get this into mainstream society? And along those lines, how do you honor the traditions that have come from generations before, from Indigenous populations, and how are they revered, acknowledged? I mean, I'm sure that's something that I know it's talked about, even from the standpoint of reparations. Do they deserve to have a part in this because of the knowledge they bring? What are your opinions on those couple of things?
Yeah, I think there's many components here to unpack. But I think one component of this has to do with, we have to understand what the package of care is here. Mm-hmm. That there are different medicines, different compounds that will have an impact, very profound impact in a person's life, in an experience, and we have to prepare that individual. So there has to be some support to prepare the individual for what this medicine can do, support them through the process, and then provide them an opportunity to integrate that experience. What did they learn from this? How does this relate to what they're suffering, and how is that experience helping them address the suffering that they have for PTSD, the trauma, for depression, all the symptoms. So that package of care, we need to understand it better. Right now, it's a really black box of what that treatment is, what's more effective and not, how does it compare to other treatments that are out there. The idea of mixing or combining medications and psychotherapy, we do that, but we don't do it in this way. You take an antidepressant, you have it takes weeks for that antidepressant to actually influence your symptoms, and you may have therapy. And they're rarely connecting to each other than, are you taking your medicine, what are the side effects, how are you addressing that, but not about what that medicine is actually doing and helping you with your depression. The therapy does that. So this is a very different paradigm. And so I think there's a lot of questions around how does this work. With the indigenous component is we definitely need to partner with people who have this wisdom, people that have done this type of work, understand sort of the history that that these medicines have, and that a lot of this is ceremonies and rituals. It's not one medicine, it's actually a whole other component that comes into play. And they also bring the understanding of what these medicines are doing within their own sort of understanding of the world, understanding of the body, understanding of the ecology. So they have an understanding of this within their culture. We have to learn about that. The issues of, for example, these medicines, there's a lot of work around the set and the setting. What you bring into this treatment will influence that, and your facilitator can help you that. And then the setting, the idea of music, of being in a very calm environment where you're comfortable, where you're being taken care of, where you're going to be with someone for 8 hours with some of these treatments. So some of those components come from indigenous communities. The idea of music is one very clearly the way music was used to enhance the experience and to help someone go through their journey. Those are the type of things. At CHIRP, we're beginning to, part of our work actually has been to partner with researchers who do indigenous work and bring them into our team and be part of our team in our discussions. And actually, some of this discussion is whether this should be commercialized. And that's a really interesting question. I'm not sure about how commercialized this could be, and what type of medicines and compounds people are doing for this. So I think there's a lot of discussions of it. The ethics of it, the appropriation component, that's also very important to consider here. And there are groups right now, indigenous groups around the world, who are thinking very carefully about this and laying out sort of what the ethical and moral components should be, so that we're not exploiting these medicines, these traditions, and bringing them all. So I think that's a really complex sort of area of work that we need to address. But we start by honoring that and also bringing those voices into the table, so that we are all talking together about this and making those decisions.
I agree with you completely on that. And this is a hard nut to crack. I mean, this is something that has so much potential, but it's so complicated at the same time. So I can appreciate the challenges that come with that.
Yeah.
So touching on the potential commercialization, if you will, of this research over time, assuming all goes well and you're seeing positive results and groundbreaking results, I'm assuming, just based on some of the initial research. How do you envision this being rolled out into the general population from the standpoint of who will administer it, and how do you envision it being accessible to people?
Yeah, so that's a really good question. And I think that, so first of all, it's a huge assumption to say that this is going to work for everyone, and that the results that we're seeing in the clinical trials that have already been published and the works are going to continue. We do need to put a word of caution on that. Things in research look very differently than when we go to the real world, to the routine practice setting. We call that a voltage drop. Usually when you're in a clinical trial, you're going to have sort of the best facilitators. You're going to screen for the best individuals that address these particular needs. You're going to have lots of attention, and we need that type of evidence to identify, is this working or not? But when you start moving to larger population, more complex issues, more comorbidities, facilitators this is not the only thing they're doing. they have other things going on in their life. The evidence might not bear out completely. So I think that's one word of caution here. We have to be careful on what this evidence is indicated, and that's why we need to move from this efficacy that we're doing right now. Does it work in, the research right now is being done, does it work in ideal conditions? That's what the FDA really needs. They need the evidence. Does this work under ideal condition? Is it safe? Is it addressing the need? And is it creating the results, the outcomes that they want? The other component is, okay, we start moving towards more routine practice settings where you have providers that are doing other things, where you have a more diverse population in terms of race, ethnicity, languages, gender, medical conditions, mental health conditions, socioeconomics. That's a very, very diverse population. Now things are a bit more complex. So we need that evidence to see, is this going to work under those conditions, and what is it that we will need? So for example, facilitators, what type of training will they need? What type of certifications and supervision they will require? Can this be done by social workers, nurses, practitioners? Those are, and some of those people can do therapy, but they cannot prescribe a medication. Mm-hmm. So who's prescribing? And then how do we address sort of the quality of that prescription, the dosaging, and all of those components. So I think there's a lot to it though. So if we scale this to larger population, we have to think about who's delivering this care, how do we prepare that workforce, and how do we supervise that workforce as it's going through the process. We also need our health insurance. This treatment cannot be scaled up if health insurance in this country is not paying for it. That's a really important component, and we're talking both public and private health insurance. What will they provide here? What will they cover? Because one of the challenges that may happen is that health insurance may cover it, but it will have a very high deductible, which makes it inaccessible for people. So I think that's another component here, and actually that's the part in CHIRP that we're bringing law into this, because we need the health law and the health policy component to understand how will this work in different service systems. In this country, we have federal programs, but they are delivering state by state. So we'll have to work with state agencies in order to do that. So those are some of the complexities that we have if we go through scale up through the medical system. We are now seeing 2 states that have decided not to do that. Oregon has gone to the route of this is not a medical treatment. This is a facilitation. They have centers, they have manufacturers, they have you don't need a prescription. If you have the means, you can pay for it, and then they have a whole set of regulations around it. And Oregon is the first step. They're out there. We're going to learn a lot about their experience of what's working, what's not. And so also learning about that will be really important. We have a study right now where we're interviewing early adopters of psychedelic assisted therapy, and we've interviewed quite a few people from Oregon, and facilitators, owners of centers, as well as people involved in the state government, and understanding what they're learning. They had to set up a whole infrastructure of this law to make it work. We're going to see the same thing in Colorado. And Colorado took a similar approach, but they have different pieces to this. So I think we are in a space right now where we're seeing how this is working in the medical model and outside the medical model. And we'll have to learn what are the challenges, what are the barriers, what are the risks. Is this helping, is it not? All of those things I think are going to be really important if we're going to bring these interventions to bear. And this is a really different type of care that we have in our mental health care system. You go to a mental health care system, if you get an hour with a therapist, you're very lucky. Most of the first lines of treatments are psychiatric medications, where you get a pill, a consultation with a psychiatrist or a primary care doctor. You might visit them for 20, 30 minutes, and that's it. This is a whole different set of time, resources, and expertise that are needed. So it's a shift in paradigm.
Completely.
That our mental health system, I don't know if it's ready for this. So that's what we're trying to figure out. how the certifications, the training, and how will this be delivered in a care system? Will it be integrated into federally qualified health centers or community mental health clinics? That could be an option, but that will require major shift in how those centers operate, how that care is delivered, and most of the places are paid by Medicare or Medicare block grants. So this has to be part of that process. Is it going to be a specialized, where you take someone and go to a specialized clinic and develop a whole other set of services, like what's happening in ketamine right now, the infusion clinics? That's a whole other component. So those are all open questions. And as an implementation scientist and a health equity scholar, those are the questions we need to be addressing right now and begin to think about what that will entail. So I think that there's lots to do here. We also can learn from other countries that are beginning to legalize and provide medical care using these treatments. Australia is one example of that. So how are they addressing some of these, the certifications, the delivery of this care, and then the impact that it may have? So those are some hopes. I worry that if this gets FDA approved, and then there's the whole other aspect of the commercialization, like beyond people that need it, the people who've gone, who have the means. Is this going to create another inequity, where if you have the means, you had access to this treatment. If you don't, this is not available to you. And that to me is very troublesome, that we bring a new care, and we see this over and over again in our healthcare system. New drugs, new treatment come into play. They're very expensive. Only certain people can access them. Other people that have need may not be able to, or not cannot access that care. That creates an inequity, and creates more problems. So we have to understand all these pieces together, and that's why we need a multidisciplinary approach here.
Absolutely.
It cannot be just one discipline bringing together. And I think hoping that CHIRP can help address some of those questions and begin to think about those questions.
Absolutely. And as far as the varying populations, whether it's self-pay or people who truly are much more need-based and have deep-seated mental problems, how do you as CHIRP get people into the study? How do you pick and choose who you are going to allow in and the results that they get?
Yeah. So every protocol has different inclusionary and exclusionary criteria. So that's an important element, that we have to screen individuals. These medicines are not for everyone. There are some questions. For example, people with history of psychosis or schizophrenia, we don't have enough evidence to indicate that these are the right treatments for those individuals. So we have to pay attention to that. If there's histories of substance use, that's another component that we have to pay attention. And other physical comorbidities. Some of these medicines have issues with your cardiovascular systems. Those are the types of things that we need to be very careful about. So in the protocols that we have right now are mostly, at CHIRP, have been mostly industry related. So they are basically we're a site to deliver that care. So they have their own specific inclusionary, exclusionary criteria, their screening systems, and we follow that. What's interesting is that we don't have to do much advertisement for this, and the need is out there. But when people learn that we have a treatment protocol here, people call us and want to be involved, and we have to then to follow the criteria. So part of this, the trials that are happening right now are really efficacy trials, so around safety. Does this intervention work? And they're very clear about who can participate and who cannot, and we have to follow those components. So we're still in this area of really honing down on does these interventions work for very specific populations. So we have protocols that are around treatment resistant depression. That's a very specific group of individuals, and have criteria for that. So those are the type of things that we need to be very careful about, and we need to follow that. That's part of the ethical responsibilities that we have to make sure that the people that are appropriate for these interventions are actually getting in.
Absolutely. And your role, what do you do? I guess if I just met you, how would you explain a day in your life of being part of this? Are you getting data? Are you interacting with anyone? Or is it more the research that you've already done and applying that to the data that's coming out of it?
Yeah. So right now, so CHIRP is, we are beginning. We're in the stages of beginning. So there's elements, my day-to-day in a sense is one, it's sort of opening a center, hiring staff, understanding all the regulatory elements that we need to have, making sure these protocols are appropriate for us. So that's one area, the administration component. The other thing is we're all doing different type of studies. So right now I have a study where I'm interviewing early adopters of psychedelic therapy throughout the United States. So doing this type, like an interview like this over Zoom, to learn about their own experiences, to learn about the challenges. It's a similar question that you brought me, you asked me about how will we scale this up? So getting information from people who are out there. And these are, we're calling early adopters, these are people who are delivering this through clinical trials, facilitators in states like Oregon, people who are getting ready to be facilitators in Colorado, policymakers at state levels. So really getting a sense of what's happening out there. So we don't reinvent the wheel and learn from them. So part of the research that I do is around that, very early stages. So I see it as we are understanding sort of the lay of the land. Where are we with this process? What are we, people who've done this, what can we learn from them? And then we're trying to bring them together and actually develop a research agenda around it. That's the other thing that we have. We have different groups around the country doing this type of work, actually around the world, but there hasn't been a concerted effort of like, what's the research agenda here? Because there's the neurological aspects of this, of understanding how psychedelics work at that neurological level. That's a really interesting research agenda, to the training of providers, to the scale up of this treatment. So part of what we're also trying to do is use participatory method. We have a group model building approach where we bring all these people in a room like this and spend 2 days using different techniques, different methods, different group exercises to bring together and come up with a research agenda for the field. So we are at those early stages for it. One thing that we're learning from it is that people really want to share ideas and create a network. And learn from what people are doing, and that's really exciting because that's the beginning of a field. And in the psychedelic work, what we're learning is that people are doing this in silos, and not because they don't like each other, because sort of the nature of this research, and some of it has to do with the commercialization of this. If you are a company and you're doing a protocol, you're not going to share that protocol with the other company that's your competitor. So there's a need for research to bring us together and begin to learn from each other around what to do. So those are some of the things day to day to do for this work. Yeah.
So how did how was this brought to the table? It was just, how does that get to a university level of, hey, we want to research this?
Yeah.
How does that happen?
So Ginger had been doing some work with Nico and Josh Siegel. They had a protocol. They have faculty who are interested in this topic, and they soldier on, find funding, and do one study at a time. So while Ginger's doing that, over the past year or 2 years, I was getting trained on psychedelic therapy, learning about that, and then we come together. And so Ginger and I collaborate on a completely different area of research. And it's actually about a year ago that we had a conversation. It's like, hey, I'm doing this. I didn't know she was doing that other study. And we come together and say, hey, we have a mutual interest here on this type of work. Let's begin to see who's out there. So with Danny Adams, who's now a assistant professor at University of Missouri in Columbia, she was a postdoc at our Center for Mental Services Research about a year ago. We started a journal club and decided, why don't we start reading the literature, invite other people that are interested in this, put the word out there and see who shows up. And we saw quite a lot of people, students, undergrad, mostly grad students, PhD students, other faculty members at WashU, and we began to read the literature and discuss it and start building sort of interest, and people from different areas of the university that were working on their own side started to come together. And that's the value of these interdisciplinary approaches for that. So that's how we began the process of it, and bring these researchers together for this. And then WashU at that time was starting with their strategic plan to develop these grants that is multidisciplinary, and it turns into this Transcend grant that we have, and that's where CHIRP comes in. We then wrote a grant for that with this idea in mind. Both Ginger and I have experience on developing centers and doing this type of work, but not in psychedelics. So we made the case, we need this for psychedelics, and here's sort of our partners. Rebecca came along. We have almost more than 10 different faculty members across the university as part of this center. So that also helped in bringing this together. Yeah.
And from what I understand, there are some unique aspects to WashU that there's research or there's different evidence that has only been found here. I don't know if that's the brain reaction. I think that was a lot of it.
Yeah, that's the area but that's not my area.
I understand that's not your area, but it's unique to the WashU. So
Yes.
your collaborative, your CHIRP and the extension of that as it grows is very unique. You're taking things that you're learning from other communities. Some, like you said, are more very medical, clinical based. Some they're kind of the wild, wild west. I mean, literally and figuratively. They're creating their own environment, but it's not as clinical, if you will, as yours. It's not as controlled, I suppose.
Yeah, I think the strength that WashU brought, and the case that we made, is that WashU is really strong. There's this thing called the translation continuum, where you start with, for example, with a medicine or a drug, where it's the development of that drug to test it and understand how it works, and then do clinical trials, and then get it all the way to the community. And WashU actually has lots of expertise along that entire continuum. So we make the case like, look, we have the basic neuroscience expertise, and we also have the implementation science expertise that we've used it for other conditions, other issues. Why don't we bring that to bear to psychedelic medicine? And that's sort of the case that we made, that we have studies all along the continuum. And we have very strong reputation and expertise in implementation science. And that's a very unique component that in psychedelic care, most of the things were over here. Does it work in ideal condition? Very few people are thinking about the next step and how to bring implementation science. So that's the other thing that we decided to do, began to do this work, bring these people together, but then we wrote an article on like how does implementation science can actually help psychedelic-assisted therapy. What are the lessons that we can learn? And we just published that in Translational Behavioral Medicine as our initial step, initial idea, to start a dialogue about these are the things that we need to be thinking about if we're thinking of scaling up. And how can implementation science help with that? So that's my expertise. That's what I brought. Ginger has more of the clinical neuroscience. She's a clinical scientist, so it's bringing that component. And then Rebecca comes with the anthropological component to this. So it's bringing all of these things into the fold to develop this type of research center.
Thank you so much for spending time with us today to discuss all this incredible information, and I know it's very early on.
Yeah.
How do you encourage other people to get engaged in the conversation? How can they get in touch with you or the group?
Yeah, so we definitely, you can contact us through our emails. I don't think we have an email from the center yet, although there is in our website. We have a new website that's going live. Within that website, people can, if you're interested in any of the protocols that we have going on, you can sign up and provide us information. We also have this journal club that is open not only to WashU's community, but actually to a larger community. And we've had people from other places come in. So signing up for that journal club will be great through our website, and you can provide the website.
Perfect.
So,
yeah. And you have other speaking engagements coming up. And do you often get out to talk about the work?
Yes, we do. We had several presentations we've done in conferences. I have a conference presentation for the Society on Social Work and Research, where we have a roundtable discussion on psychedelics and social work. And we have a special interest group now within the Society of Social Work and Research on psychedelics. That it will be the first meeting. This is happening in Seattle in the middle of January. And the annual conference of the Society for Social Work and Research. So,
wonderful. Well, we wish you the best of luck. It's amazing research, a lot of untapped potential, and I'm sure it will be interesting to follow.
Awesome. Thank you so much for the opportunity, and thank you for all this.
Absolutely. Thanks. You've been listening to Life Beyond Loss, a podcast from Survival in the Trenches. If you'd like to get involved and help those struggling to cope with personal loss, visit us at our website, survivalitt.com, and follow us on social media. Don't forget to subscribe and share this podcast so we can continue to grow and reach more people in need. Together, we can make a difference.